Good afternoon, everyone. It's truly a pleasure to be here today. Again, my name is Golena Fernandez Moncaleano, and I have the privilege of working at the University of Michigan, where I've been fortunate to be part of both the Department of Urology and the Michigan Urological Surgery Improvement Collaborative, well known as MUSIC. So today we're going to a couple of very interesting topics. But first, I would like you to know more a little bit about me. And then we're going to spend a few minutes talking about ureteroscopy, the trends in the modern endourology. After that, we're going to understand why postoperative hydronephrosis matters. After that, we're going to have some words about controversies and considerations regarding postoperative imaging. And the most important part, which is always the last one, will be, can we be mindful with postoperative imaging? Before diving in, let me tell you a little bit about myself. I come from Neiva, a small town nestled in the southwest of Colombia in South America. And after completing my urology training, I decided to continue sharpening my skills in endourology by pursuing a clinical fellowship in Caracas, Venezuela. I returned home to practice, but as life often does, it brought me on a different path. And for family reasons, I relocated to the United States, where I was very lucky enough to land in the winter water wonderland, Michigan. Since then, I've had the incredible opportunity to work and learn at UMich and to be part of music. This journey, both personal and professional, has led me to today's topic. Before diving deeper into today's topic, I want to take a moment to recognize the people who have made my journey in the United States not only more meaningful, but truly transformative. These are individuals who have offered me not just knowledge, but time, trust, encouragement, and opportunities. Dr. Aruna Sarma, who is here, whose leadership in research and dedication to mentorship have guided me in shaping thoughtful, impactful questions. And Dr. Kurchit Ghani, who is also here, and Dr. Casey Do, who has shown me how collaboration and data can truly transform surgical care through programs like music. I'm deeply grateful for their support, their wisdom, and believing in me. Thank you. I'd like to take a moment to introduce you to the Michigan Urological Surgery Improvement Collaborative, or MUSIC. MUSIC is a physician-led statewide quality improvement initiative supported by Blue Cross Blue Shield of Michigan. It brings together over 260 urologists across 46 practices, both academic and community. This is the power, academic and community, all working toward one shared goal, making Michigan #1 in urology care. Music is not just a registry. It's a collaborative learning network focused on improving outcomes across several urologic domains, including prostate cancer, kidney, renal masses, and importantly for today's topic, kidney stone surgery. Within music, I have the privilege of working on the ROCKS initiative, which stands for Reducing Operative Complications from Kidney Stones. ROCKS focuses on optimizing care before, during, and after stone treatment. And it's through this work that I've been able to study real world patterns, identify practice variation, and ask timely clinical questions like, who is truly at risk for postoperative hydronephrosis after ureteroscopy? I invite you all to learn more about music and its initiatives by visiting musicurology.com. You already know that my talk is postoperative hydronephrosis after ureteroscopy, who is at risk. But let's first talk a little bit about ureteroscopy. This procedure has become the most commonly performed surgical intervention for upper tract stone disease in the United States. With advances in laser technology, in digital scopes, and disposable devices, it's not surprised that indications for ureteroscopy have expanded a lot. However, with greater adoption comes greater variation in preoperative management, instrumentation, and importantly, in postoperative care. One particular area where this variability is pronounced is postoperative imaging, And that brings us to today's focus. Despite the efficacy of the ureteroscopy, is not without risk. Ureteroscopy is not without risk. And one important postoperative complication is hydronephrosis, which may indicate inflammation, obstructive stone fragments, fibrosis, ureteral stricture. All of those conditions may be silent or symptomatic. So, how do international guidelines addresses the question of postoperative imaging after ureteroscopy? Let's start with the American Urological Association. The AUA recommends postoperative imaging to assess for stone clearance and obstruction, though it doesn't specify the timing or modality. It doesn't specify that. This leaves significant room for clinical judgment, but also potentially for variability in practice. Now, looking at the European Association of Urology, the EAU provides recommending imaging at 4 weeks postoperatively. In short, both guidelines recognize the importance of imaging after ureteroscopy, but neither mandates a strict protocol. And this underscores the core issue of this talk. Without clear, specific recommendation, variation in practice is inevitable, and patients at risk of complications may be missed. That's exactly where programs like music and rocks can lead by building data-driven, consensus-based pathways that improve care consistency while respecting individual patient needs. One of the key reasons we obtain postoperative imaging is to evaluate for persistent hydronephrosis, which may signal, we already said, residual stones, obstruction, or complications like ureteral stricture. Persistent hydronephrosis is not rare. The clinical implications can be significant. Delayed diagnosis of obstruction can result in loss of renal function or infection, while overdiagnosis can lead to unnecessary procedures. So the question becomes, are we imaging the right patients at the right time for the right reasons? Why was the AUA interested in assessing hydro? Well, there is a 3% rate of asymptomatic postoperative hydro that may end in the need for reintervention, and in the worst scenario, renal function replacement. Yes, I don't want to omit the possibility of losing a kidney, so that worries us as a urologist. Currently, there's no consensus on who should receive postoperative imaging, what modality is best, or when it should be done. Some providers obtain imaging universally, others do so selectively based on stone burden, intraoperative findings, or patient symptoms. The choice of imaging modality also varies from renal ultrasound to KUB to CT scan, each with its own balance of sensitivity, specificity, cost, and radiation exposure. This heterogeneity reflects a gap in evidence-based guidance and perhaps a need to move toward more mindful imaging strategies. Let's now take a closer look at real-world imaging practices after ureteroscopy. This figure shows the cumulative rates of postoperative imaging over time, at 3 months, 6 months, and up to 12 months after the procedure. What's striking is that even at the earliest interval, 3 months, which is when most clinicians will expect to evaluate for residual fragments or obstruction, over half of patients, 55%, receive no imaging at all. As we extend the follow-up to 6 months, nearly half of patients, 48%, still had no imaging. And even after full 12 months, 39% of patients have never received any postoperative imaging. These findings raise important concerns. We know that postoperative imaging plays a key role in detecting silent obstruction, residual fragments, or stricture, all of which can be asymptomatic but lead to long-term harm if missed. Yes, this data suggests a significant gap between guideline recommendations, which are not very clear, and actual practice. This data that I'm going to show you is from music. It's a prospective collection of clinical information across practices in Michigan from June 2016 to July 2017. And it includes patients who underwent ureteroscopy for stone treatment. And we specifically look at whether they received any imaging within the first 60 days after surgery. We found that the most common modality was AXR, using 55% of cases, followed by ultrasound in about 22%, and CT in only 11% of cases. But perhaps the more importantly part of this is that only 48% of all patients receive any form of postoperative imaging within that early period, 60 days. And when we look deeper, we observe substantial variation across providers in how and even if they use imaging. This variation tells us that we don't yet have a standardized, evidence-based approach for postoperative surveillance after ureteroscopy, despite its clinical relevance, especially when we're trying to detect hydronephrosis or residual fragments. The controversy around postoperative imaging remains very much alive when we review the current literature. Some authors argue that routine radiologic surveillance is not necessary for asymptomatic patients after ureteroscopy. Not at all, unless there was ureteral perforation, which is associated with a higher risk of stricture formation. Others recommend performing excretory urography, CT, or ultrasound within 3 months postoperatively to reduce the risk of missing silent ureteral obstruction. Another perspective suggests that imaging should be symptom and risk guided. And another perspective, ultimately, the last one that we have from now patients that have been intervened with lasers mention that routine upper tract imaging is not universally indicated. Most experts agree that it should be reserved for selected scenarios. Which are those scenarios? They include chronic stone impaction, significant ureteral trauma, pre-existing renal impairment, endoscopic size of stricture, or postoperative symptoms such as flank pain or fever. But all of these features are related to the intraoperative scenario, and we want to understand and to assess which preoperative characteristics of the patients may impact in the future development of postoperative hydronephrosis. So at the end of the day, after the ureteroscopy is done and the patient has go home, what do we really want to know as a urologist? It's actually quite simple. It can be simple but critically important. One, is there any hydronephrosis? And two, are there any residual stone fragments? These two questions drive our concern for silent obstruction, recurrent symptoms, and the potential need for further intervention. And yet, as we've seen, imaging isn't always performed, meaning we may be missing key information that could change management. This is where thoughtful risk-based postoperative imaging strategies become essential. Not just imaging more, but imaging smarter, guided by patient factors, procedural details, and risk of complications. And let's be real, our stone rates in Michigan aren't great. 49% for stones in the kidney, 72% for stones in the ureter. This is important to understand because residual fragments have real clinical consequences, including emergency department visits and the need for reintervention. In fact, the likelihood of repeat surgery after ureteroscopy is directly proportional to the size of the residual fragments. For example, within 5 years, the reintervention rate for stones larger than 2 millimeters is not negligible. Moreover, patients with residual fragments of 4 millimeters are in the greatest risk of subsequent stones-related event, and up to 30% of them will require a second surgical intervention. So let me ask you, if you were the patient, wouldn't you want to know if you were in that high-risk group? So these so-called insignificant residual fragments may not be so insignificant after all. But how do we actually measure residual fragments and hydronephrosis? This brings us to an important point. There are several limitations when using renal ultrasound to assess stone-free status. Now let's take a closer look at the accuracy of ultrasound for detecting renal stones and determining stone size. This is an important question because while ultrasound is non-invasive, inexpensive, and radiation-free, its diagnostic accuracy has limitations. First, study shows that ultrasound can falsely suggest the presence of a stone in 10 to 20% of cases, meaning it may indicate a stone when no stone is found on CT or gold, which is our gold standard. And second, ultrasound tends to overestimate stone size. This can impact clinical decision making, especially when treatment thresholds depend on stone diameter. And finally, when it comes to assessing stone-free status, ultrasounds have limited sensitivity. Small residual fragments may be missed, which can lead to an inaccurate classification of outcomes. And here we have CT diagnostic characteristics that may be way better in terms of sensitivity and specificity. But you may tell me, okay, but what about radiation? I'll show you some information in the next slides. And this is why in 2023, the Journal of Urology introduced a significant change. All studies reporting stone-free rates must now base their assessment on non-contrast CT scans. This mandate aims to standardize reporting and enhance the accuracy of postoperative evaluation. So considering that there is no consensus on who should receive postoperative imaging, what modality is best, or when it should be done, we think that some providers obtain imaging universally, others do so selectively based on stone burden, intraoperative findings, or patient symptoms, and the choice of imaging modality also varies. So my question is, can we be mindful with postoperative imaging? Should we rethink how we can predict who's at higher risk of postoperative hydro? Because if we can, we might improve how we use postoperative imaging. So we may start thinking about smarter strategies for safer care. We use data from the Michigan Urological Surgery Improvement Collaborative, utilize the Reducing Operative Complications from Kidney Stones Registry, which is called ROCKS, and look at all ureteroscopies done for stone treatment across the state from 2020 to 2023. We focus on patients who had both preoperative and postoperative imaging, specifically CT or ultrasound within 29 to 60 days after surgery. And this specific time was intended to avoid transient hydro. Then we made some multivariable mixed effect logistic regressions to determine preoperative clinical factors associated with postoperative hydronephrosis, with predicted probabilities from the model used to illustrate the risk. We retrospectively identified nearly 19,000 patients who underwent ureteroscopy between July 2020 and June 2023. And among these, the 94% of patients underwent preoperative imaging, which is a really good number. But of these, just 24.3% underwent postoperative imaging within 29 to 60 days of surgery, with available data on the presence of postoperative hydronephrosis just in 10% of those patients. In the multivariable analysis, several factors were significantly associated with the likelihood of postoperative hydro. Preoperative hydro was found to significantly increase the odds of postoperative hydronephrosis with an odds ratio of 1.97, almost twofold. Similarly, a larger maximum stone diameter was associated with higher odds of postoperative hydro with an OR of 1.04. Female gender was another significant predictor. And when comparing the largest stone location, patients with the largest stone located in the kidney had significantly higher odds of postoperative hydro. These figures shows the predicted probability of postoperative hydronephrosis in patients with preoperative hydronephrosis on your left and patients without postoperative hydronephrosis in your right. Our findings indicate that female patients, the dot line, the red dot line, the female patients with renal stones and preoperative hydronephrosis are at the highest risk for postoperative hydronephrosis with a predicted probability nearing 30%, is this line, for a stone size of close to 20 millimeters. In contrast, male patients, the solid blue line, male patients with ureteral stones without preoperative hydronephrosis exhibited the lowest risk with an estimated 6% probability of postoperative hydronephrosis. What is important here and very interesting is that if you see the numbers, 82% of patients that present with postoperative hydronephrosis had previous hydronephrosis, and just 18% of patients with postoperative hydronephrosis didn't have hydronephrosis. So after viewing these images, we need to be most concerned about when it comes to postoperative hydronephrosis, who is at risk. It may not be just the universal imaging for all the patients. We may need the risk to understand the risk of each patient for postoperative hydronephrosis. So based on our analysis, we can stratify patients into risk categories. The highest risk patients include those with renal stones and preoperative hydronephrosis, patients with large ureteral stones and preoperative hydronephrosis, and interestingly, females with large renal stones even without hydronephrosis preoperatively. These patients are at greatest risk for developing persistent or new hydronephrosis after ureteroscopy, and they may benefit from closer follow-up and imaging. And in the lowest risk, the patients are those with small ureteral stones and no preoperative hydronephrosis. These patients are the most likely to do well without complications and may not require routine imaging, especially if they remain asymptomatic. So again, the message is not all patients are equal when it comes to follow-up. Risk stratification can help us personalize postoperative imaging decisions. We acknowledge the limitation by the retrospective design of the study, which may be subject to selection bias. And another significant limitation is the variability in imaging protocols, as imaging modality was conducted at the discretion of individual urologists rather than following a standardized protocol, which is a common issue that many studies report today. Even though postoperative imaging was ordered, the fact that imaging was not performed in 75.6% of patients potentially leads to incomplete assessment of postoperative hydronephrosis. After reviewing our results, we thought that an approach based on risk stratification is essential for optimizing postoperative imaging decisions. But before presenting our goal-directed approach, I want to make a comment. If you can kill two birds with one stone by assessing for stone-free rates and hydro with a CT scan, would you do it? Concerns about radiation exposure are valid, but ultra-low dose non-contrast CT protocols have the same amount of radiation as a KUB while providing a comprehensive assessment of hydronephrosis and stone-free rates. Here is the goal-directed approach proposed by MUSIC, where if you are looking to evaluate hydronephrosis, we recommend renal ultrasound, and a point-of-care ultrasound in office may be considered. If you're interested into addressing residual fragment evaluation, a KUB is okay for us, but we strongly recommend low-dose renal CT. And if you have a symptomatic patient, a low dose stone protocol CT is recommended. And perhaps something that is new and we have been very minded to understand is that in the specific scenario of a patient with low risk characteristics, such as no preoperative hydronephrosis and a small ureteral stone, postoperative imaging may not be necessary. So, in short summary, imaging rates are still low, not just in Michigan, in the whole United States. Postoperative hydronephrosis is not rare, it occurs 1 out of 10 patients in Michigan. When considering imaging postoperatively, we recommend a goal-directed approach. It means, what are you looking for? Are you looking for the hydro? Are you looking for the stone-free rate? Or are you looking for both of them? And factors such as preoperative hydronephrosis, stone size, gender, and stone location impact the likelihood of postoperative hydronephrosis and could be used to guide imaging strategies. Those patients at greatest risk are those with preoperative hydronephrosis or no preoperative hydronephrosis but large renal stones. And finally, we may be able to avoid imaging in those with small stones and no preoperative hydronephrosis.